I want to tell you something that took me over 20 years in surgery to fully understand. And honestly, I wish someone had told me sooner. Before I watched it happen to patients I genuinely cared about. Surgery saves lives. I have seen it do extraordinary things. I have held a beating heart in my hands and repaired it. I have watched people walk out of my hospital who should not be alive. I believe in surgery deeply. But here's the part nobody talks about. After the age of 65, your body does not experience surgery the way it did at 40. It does not bounce back the same way. The margin for error shrinks. And there are 5 specific surgeries, common ones your doctor might recommend without a second thought, that I would not let my own parents have without a very serious conversation first. Not because these surgeries are wrong, not because medicine is broken, but because I have seen too many times what happens when the body's reserve runs out in an operating room, and I refuse to stay quiet about it. My name is Dr. Joseph Lee. I have spent over 2 decades in surgical medicine, and today I am going to walk you through all 5 of these surgeries, explain exactly why they become more dangerous after 65, and most importantly, what you can do instead. All references are in the description below. I am not asking you to blindly trust me. Check the science yourself. That is what good medicine looks like. Before we get into it, what country are you watching from right now? Drop it in the comments. And have you or someone you love ever been through a major surgery after 65? Tell me what that experience was like. I read every single comment, and your story might help someone else who is facing this exact decision right now. The framework. Why age changes everything. Before I give you the list, I need to give you one concept, because without it, what I am about to say will not fully land. The concept is called physiological reserve. Think of your body like a rechargeable battery. When you are 35, that battery is full. You get sick, you recover. You have surgery, you heal. You have a bad week, and your body absorbs it and keeps going. The reserve is deep. But here's what aging does. It quietly drains that battery, not dramatically. You might feel completely fine at 68, 72, 78. You walk, you cook, you take care of your grandchildren. The daily draw on that battery is no problem. The problem is that major surgery is not a daily draw. A major surgical procedure, the anesthesia, the incisions, the trauma of healing, that is like plugging an industrial machine into a household outlet. And if your battery is already at 50 or 60%, that surge can take you to 0. This is why researchers at Johns Hopkins, studying hundreds of elderly surgical patients, found something that should be required reading for every patient over 65. Physiological reserve, not age on a birth certificate, predicted complications, hospital readmissions, and long-term outcomes better than almost any other factor. Now, here's the other thing I need you to understand. The real danger is almost never the planned surgery. It is the emergency surgery. The surgery that happens because something manageable was left alone until it became a crisis. The gap between a planned procedure and an emergency one is not a small difference in convenience. It is often the difference between outcomes measured in recovery days and outcomes measured in survival. Keep that in mind as we go through this list, because almost every surgery on it follows the same pattern. Surgery 1, emergency bowel surgery. Let me start with one that sends more people over 65 to the ICU than most families ever realize. Emergency bowel surgery. The removal of part of the large intestine under urgent conditions. Here's how people arrive at this moment. The colon develops problems quietly. Small pouches in the wall, called diverticula, can become inflamed or rupture. A tumor can grow for years without a single symptom loud enough to make someone call their doctor. And then one day, something ruptures or blocks, and infected material spills into the abdominal cavity. That is an emergency. There is no preparation time. The abdomen has to be opened immediately. In a planned surgical setting, a bowel resection is serious but manageable. In an emergency, with a body already in septic shock, the math changes completely. Large studies of adults over 65 who undergo emergency colorectal surgery show in-hospital mortality approaching 16%. In patients who are frail, published research documents rates exceeding 25%, 1 in 4. Now let me ask you something honestly. Think about the last time you or someone close to you noticed a subtle change. A shift in bathroom habits, a dull ache in the abdomen that comes and goes, and filed it away. Assumed it was something they ate, figured it would pass. That response is natural. The body self-corrects all the time. But colon cancer does not self-correct. Diverticular disease does not self-correct. They progress. And the window between this is something we can address with a scheduled procedure and this is now a life-threatening emergency can close very quietly. Here is the good news, and I want you to hold on to this. A colonoscopy from age 45 to 50 onward gives your physician direct visualization of the entire colon. Precancerous polyps, the cells that over years become cancer, can be removed in the same procedure. You walk in, you walk out, you are done. That is the alternative. A Tuesday morning outpatient appointment versus a 1 in 4 chance in an emergency room. Do not wait for the emergency. Schedule the appointment. Surgery 2. Emergency perforated ulcer repair. Here is one that surprises people because it often starts with something so ordinary. A peptic ulcer is an open wound in the lining of the stomach or upper small intestine. The two most common causes are a bacterium called H. pylori and the regular use of anti-inflammatory medications, ibuprofen, naproxen, aspirin, taken for arthritis or joint pain. And I want to pause on that for a moment, because if you are over 65 and you take an anti-inflammatory most days to manage chronic pain, you need to hear this. NSAIDs work by blocking certain enzymes that drive inflammation. But those same enzymes maintain the protective mucus lining of your stomach. When you suppress them over months and years, that lining thins. Stomach acid begins eroding the exposed tissue. Most ulcers found early are treated without surgery. Proton pump inhibitors reduce acid and allow healing. If H. pylori is present, a short antibiotic course clears it. In the vast majority of cases, the ulcer closes. The danger arrives when the ulcer is left untreated, deepens, and eventually perforates, breaching completely through the stomach wall. Stomach contents enter the abdominal cavity directly. The pain is sudden and absolute. Surgery becomes the only path forward. For adults over 65 undergoing emergency perforated ulcer repair, 30-day mortality sits between 15 and 25% in published studies. Postoperative complications, kidney injury, respiratory problems, delirium, affect a substantial proportion of survivors. Now here is the moment I need you to pause on. Think about someone you know, maybe yourself, who takes an over-the-counter anti-inflammatory every day. Ibuprofen for a bad knee, naproxen for a shoulder. There is no dramatic warning on the label. It has been in the medicine cabinet for 15 years. It feels completely safe. The question to ask your physician is simple. It takes 30 seconds. I take an anti-inflammatory regularly. Should I also be taking a proton pump inhibitor to protect my stomach lining? That one question and the answer to it may be all that stands between your current situation and a surgical emergency. Surgery 3. Emergency small intestine resection. This one requires you to think carefully about a symptom that almost everyone has experienced and almost everyone ignores. Stomach cramps, nausea, vomiting. When those symptoms arrive, the natural response is to give it a day. Stay home, drink water, hope for improvement. Most of the time, that is exactly right. A stomach upset resolves. Life continues. But in an older adult who has had previous abdominal surgery, or who has a known heart condition or atrial fibrillation, that same symptom cluster can be the early presentation of something far more serious, a bowel obstruction. Or worse, intestinal ischemia, when a blood clot lodges in one of the arteries supplying the small intestine, cutting off blood flow to tissue that begins dying within hours. The small intestine is where your body absorbs almost all of its nutrition. When a portion of it loses blood supply, the consequences accelerate rapidly and become very difficult to reverse. If the affected segment is extensive and requires surgical removal, the remaining intestine may be unable to absorb adequate nutrition from normal eating. That is not a temporary outcome. That is a permanent change to how someone lives. The difference between catching this at 6 hours and catching it at 48 hours can be the difference between a hospital admission with an IV and losing a significant portion of the intestine permanently. Here is what I want you to remember. I am not suggesting that every stomach ache warrants an emergency room visit. It does not. But in adults over 65 with prior abdominal surgery or significant cardiovascular history, abdominal pain that persists beyond a reasonable window, especially alongside vomiting, deserves medical evaluation. A CT scan provides a diagnosis in minutes that can distinguish something benign from something that requires immediate action. Act on the unusual pattern. Not every ache, but the one that is different. Surgery 4. Delayed appendectomy or gallbladder removal. Now here is one that surprises people because these are two of the most common operations in the world. I am not saying appendectomies and gallbladder removals are dangerous surgeries. In most cases, they are not. I am saying that delay transforms them. And older adults are uniquely, specifically vulnerable to the pattern that turns a routine operation into a major one. Let me explain what I mean. In a younger adult, appendicitis announces itself with localizing pain in the lower right abdomen, fever, and nausea that escalates in a way that is very hard to ignore. Most younger people are in an emergency room within hours. The appendix comes out before it ruptures. The surgery is laparoscopic, about an hour, and the patient goes home the next morning. In adults over 65, the same condition frequently presents with symptoms that are vague, mild, and easily explained away. The pain might be diffuse. There may be little or no fever. The classic presentation simply does not show up. So the natural response is to wait and see. By the time the picture becomes undeniable, the appendix has often already perforated. The infection has spread from a contained, removable structure into the entire abdominal cavity. What would have been a laparoscopic surgery with same-day discharge becomes open surgery, drains, weeks of recovery, and a dramatically different set of statistics. The mortality for uncomplicated laparoscopic appendectomy in any age group is less than 1%. Perforated appendicitis in older adults carries documented mortality rates of 5 to 10%, rising sharply in those who are frail. The same pattern plays out with gallbladder disease. An early intervention is manageable. A gangrenous gallbladder with surrounding infection is not. Here's what I want you to take from this one. Abdominal pain that is new, that is not clearly explained by something you ate or a known pattern, and that persists beyond a day in an older adult, that is not a candidate for continued watchful waiting at home. That is a candidate for evaluation. Because the same procedure performed 24 hours sooner is categorically a different surgery. Act earlier rather than later. That is the entire safe alternative here. Surgery 5. Major surgery without preparation. This last one is different. Every surgery we have discussed so far had a clear do this instead. Colonoscopy, medication conversation, early evaluation. This one is different because sometimes you cannot avoid the surgery itself. A hip fracture needs repair. A lung tumor needs to be addressed. The surgery is coming. The question is not whether, it is how the patient arrives at it. Let me give you the numbers plainly because they deserve to be said out loud. 1-year mortality following hip fracture in adults over 65 ranges from 17 to 25% across major published studies. And hip fracture reveals something about the body that was already significantly depleted before the fall ever happened. Bone density, muscle mass, balance, cardiovascular reserve. Major thoracic surgery for lung cancer carries compounding risks in older adults. Removing a lobe of lung directly reduces respiratory capacity. The combination of general anesthesia, chest wall disruption, immobility, and reduced reserve creates exactly the conditions for the most feared complications: pneumonia, pulmonary embolism, postoperative delirium. Here is the part I most want you to hear. Most people, when they receive a surgery date 6 weeks away, spend those weeks waiting, anxious maybe, planning for time off, but not physically preparing, because the medical system does not usually present it that way. You receive a date, a preoperative checklist, instructions to stop eating the night before. The assumption is that you will arrive in whatever biological condition you happen to be in. But what if you arrived in significantly better condition than that? This is called prehabilitation, and it is one of the most powerful tools available to older adults facing planned surgery. It is not vague wellness advice. It is structured, targeted preparation with 3 components. First, physical exercise. Supervised aerobic and resistance training that targets the muscle groups most burdened by the specific surgery. Leg and core strength for hip surgery. Respiratory muscle training for thoracic surgery. A patient who arrives at the operating room stronger than they were 8 weeks earlier heals measurably faster. Second, nutritional optimization. Many older adults carry protein deficits that are not clinically obvious until the body is asked to heal under surgical stress. Weeks of targeted protein support before major surgery has been shown in multiple trials to improve wound healing and reduce muscle loss during recovery. Third, psychological preparation. Anxiety before major surgery is not just an emotional experience. It is physiological. Elevated cortisol, disrupted sleep, heightened nervous system activation. All of these impair healing. Understanding what the procedure involves, having a clear recovery plan, and reducing preoperative anxiety has documented effects on outcomes, including postoperative delirium. A randomized controlled trial published in JAMA Surgery found that a multimodal prehabilitation program reduced postoperative complications and improved functional recovery compared to standard care. That research exists. Most patients never hear about it. For hip fracture prevention, which is where I want your attention if you have aging parents, vitamin D supplementation at 800 to 1000 IU daily has been associated with reduced fall risk in multiple trials. Balance and strength training programs designed for older adults reduce fall rates by 20 to 30% in well-designed studies. And a medication review. Sitting down with a physician to identify which current prescriptions carry fall risk as a side effect is one of the most directly actionable steps available. If a major planned surgery is on the horizon for you or someone you love, the most important question to ask at that appointment is not only when the procedure is. It is what can I do between now and that date to arrive in the best possible condition? If your care team does not have a ready answer, ask again. That question, asked and answered, can change everything that happens on the other side of the operating room door. Every surgery on this list shares the same root cause. None of them are failures of surgical technique. None of them are bad luck. They are the consequences of a problem that was manageable and became a crisis. A problem that could have been found, treated, or prepared for, and was not. Not because anyone was careless, but because nobody explained how the rules change after 65, how the body's reserve works, how the gap between early and late, between planned and emergency, is not a small difference in inconvenience. It is often the difference between outcomes measured in hospital days and outcomes measured in survival. The operating room is not the enemy. Surgery done at the right time, with appropriate preparation, is one of the most powerful tools in medicine. I have seen it give people decades they would not otherwise have had. But surgery is also a massive physiological event. It demands reserve. And in a body where that reserve is limited, the margin for error narrows. You have more agency over those variables than you probably realize. The colonoscopy you have been postponing, the medication question you have not asked yet, the symptom you have been quietly normalizing, the preparation program that nobody mentioned when they handed you a surgery date. These are not small things. They are the decisions that determine which version of the story you live. If anything in this video applied to you or made you think of someone you love, please share it. Not to alarm them, to start a conversation that might matter. And if you have questions, leave them in the comments. I read every single one and I will do my best to respond. Stay informed, stay proactive, and take care of the only body you have. I am Dr. Joseph Lee. I will see you in the next one.